Lunch with the Core. Our speaker today is Dr. Sarah Burris from Visual Sonics.
Great. Thanks, Glenn. Thanks, Adrian, for the invitation. It's great to be here. I'm here with my colleague, Bret Hawkins. So we're very happy to answer any questions that anyone has related to the Vevo F2. I'm not sure if you're familiar with Visual Sonics. We're actually an ultrasound and photoacoustic company. We've been in business for more than 20 years, and we've pretty much dominated the preclinical imaging market for most biomedical research. So you'd be pretty hard pressed probably to go to a conference and not see one of our systems because we have over 1,700 of them installed worldwide. So for those of you that aren't really familiar with ultrasound, or maybe you don't really know too much about preclinical ultrasound, basically ultrasound is the same thing you've heard of in the clinic, used for pregnancy monitoring, used for echocardiography. What ultra high frequency is, which is what we specialize in, has to deal with the frequencies of the transducers. So most of your clinical transducers run between 3 and 15 megahertz. That's great because you can get deep in a human and visualize relatively large structures. But most of you are working in small marine models. So you need to see a tiny little heart that's beating inside of a mouse, which is roughly the size of a coffee bean. So our frequencies go all the way up to 71 megahertz. And that allows you to get really great visual clarity of these very small structures in things like mice, zebrafish, chick embryos, whatever you might want to be imaging. So really, high frequency translates into high resolution. So just to kind of illustrate this point a little bit, this is a mouse heart imaged with one of our clinical ultrasound systems. So again, you can kind of see some structures there. Let's see how this laser works. Oh, there we go. No, there. So you can, see roughly that football shape of the heart, your long aorta kind of branching off. That's okay. You can probably get some rough measurements on it, but it's not going to be anything that's really fine detail. This is what that same structure looks like with the Visual Sonics system. So you see really high resolution here. You can see a valve that's actually flipping back and forth, occasionally coming into frame. You can see blood pooling around. These are the things that are going to give you very precise measurements when you're going to do your preclinical work. So I don't know if we have a lot of postdocs in the room, PIs that came from other institutions. We've had a series of systems released over these 20 plus years that we've been in business. The Vevo F2 is our new flagship system. This was just released in June of this year. So it is like the newest, best thing that you would potentially be going for. This system now carries low frequency transducers as well. So lower frequency transducers means we can go to bigger animals. We're gonna start doing rabbits, dogs, pigs, these types of things. So it's a system that you can literally do zebrafish and pig imaging. No other system on the market can do that type of imaging. Our system also has something called VADA mode. Is anybody in the audience an acoustic engineer, bioengineer? All right, then we're going to go really quickly through this because this might be a little bit outside of your realm of expertise. Basically what this means is most of the time when you're doing ultrasound imaging, you only care about the image that's being churned out. But if you're someone who works in acoustic engineering, you want to change things on the front end before the signal is generated, because you want to go in and do these crazy types of imaging where you need to change the different wavelengths, the different voltage, the different speeds of the sound wave that's being generated. So our new system allows you to do this. And I'm not going to run you through all the channel basics because, again, this is going to be slightly out of your realm. But you have a lot more control of what you can do on the front end. And then there's a lot of interesting post-processing techniques that you can do on the back end. So this is more of an engineering type of thing. This is someone who's going to be working in MATLAB designing scripts to put into the system. For those people that might be listening to this recording, you can go in, you can change transmit delays, you can change the waveforms that you might be interested in generating, pulse sequences, and I will say that there are really only one other system on the market that can do this, but it is like the basement engineer's system. It is someone hacking away on their computer to generate these scripts, to manually put them in, and then generate all these different contraptions to send speed of sound through water apparatuses. Our system is like a puzzle piece. It allows you to not make mistakes when you're going through and constructing these sequences. So it really is great for people that are learning bioengineering. They can get in and use the system right away because it will kick out an error signal if you put something in the wrong order. It won't allow you to fry a transducer because you put in the wrong voltage line with the wrong waveform. So what does this mean? Well, you can do plane wave imaging techniques. This is for ultra-fast Doppler work. You can do super resolution, so tracking little tiny moving micromolecules that are going through the blood. You can do signal processing and beamforming, and then tissue characterization, which is elastography. Okay, so if all of that went over your head, don't worry. The rest of this talk is going to be geared towards you because the rest of the system is really push button. You push a button, you get a beautiful image that comes out. So how do we do this? Well, we have different types of things built in the system, like HD image processing. So it's going to give you beautiful HD processed images. This is going to give us really nice resolution. So this is the carotid artery. You can see this is kind of an older system on the left. You get a nice bifurcation, but we lose this real distal portion of the image. HD imaging gets rid of all this noise or artifact that's there and allows us to actually see the distal portion of the vessel. So if you're working in pulse propagation velocities, meaning you want to see how long it takes for blood to get from here to here, because this is a measure of arterial stiffness, you can do that with a lot more ease than you could on any of our previous models. This is also very intuitive to use. If you've seen any of our old systems, it's like a big keyboard where you're looking for all these different buttons. New systems, touchpad. So you go in, you get your home screen, you say, okay, this is my transducer that's connected. I want to do small rat cardiology. I push that button. It's going to automatically kick you into the screen that has the ideal depth, the ideal frequencies, everything that you would need to just go. You don't have to program anything. There's also a nice help option. So you can go into that menu and it's going to have video tutorials. How do I position the transducer? How do I prepare the animal? What should the image look like that I'm actually going to acquire? So you don't need to have a computer sitting there if you're in a basement core facility trying to image and you don't have any internet access. This has it all built onto the system. Once you go into the system, this is what your imaging screen looks like. Let's say you're a person who's solely interested in color Doppler imaging. I don't need all these extra buttons. Just swipe them to get rid of them. I want customized settings on the bottom. Pull those down over the more controls. So this is customized to what you do for your individual profile. So when you log into the system, connect your transducer, pick how you want to do your imaging, and then it opens up your settings again. You can put 35 people on here if you want to with their individual customized settings. And it will go back to that every single time. So you don't have to worry about, oh no, I imaged this animal last week and then suddenly I put the wrong parameters in this week and it's not going to match my previous cohort of images that I took. Take all that guesswork out. So our new system is really ideal for working small to large animals, doing the acoustic engineering, and doing all of the biological, physical imaging that you want to do. Now, one thing about this new system, it has 2 new transducers that we've never offered before. We have a low frequency linear array, so these 2 all the way on the right-hand side. This is going to be ideal if you want to do your large animal work, large rats, pigs, rabbits. We also now have a phased array. What does this mean? Well, a phased array is different from a linear array. A linear array is essentially a straight line. You've got multiple beams coming down. A phased array is going to kick out that little triangle structure because you've got one point of all of those arrays coming in, and then it fans out. So what does that allow you to do? It allows you to work in between ribs. Bones are the enemy of ultrasound. You can't really get through them very easily. So you want to be able to move around all these structures. Our system also comes with a whole animal physiology setup. Animals get cold when they're anesthetized. If animals get cold, that's going to slow down their cardiovascular function. That's going to greatly affect your perfusion kinetics. This stage will help to keep them warm. You also have monitoring of their ECG and respiration rate. You can do 3D imaging with this. You can do guided injections into your animals with this particular setup. So I'm only going to talk about 4 different types of applications today, because those are the ones primarily of interest in the application that was submitted through the Carver Trust Foundation. But we really have a variety of animal models people are working in. They're working in infection, ophthalmology, urogenital type of imaging. And we have over 5,000 publications validating the technology. So again, you'd be pretty hard pressed to go somewhere and people would say, what is this? I've never heard of this thing before. It's very validated work. So let's start off with talking about cardiology and cardiotoxicity. So I'm going to kind of run you through a variety of imaging techniques to show you what we can do. So your 2100 system that's somewhere on campus, I don't think it's really accessible to most of you, can generate a cardiovascular image that looks like this. So if you take your heart, those of you that aren't in cardiology, you've got the base of the heart and the apex is kind of hanging down like this. We've taken this heart, put it on its side, and taken like a bread loaf slice down the middle of it. So we have our 2 papillary muscles here on the side, your anterior wall, posterior wall, and septal wall. In addition to the HD imaging, these newer systems have what's called spatial compounding in the transducers, which basically allow the beams to hit the structure at multiple angles. This allows vascular walls to really pop, and it also gets rid of artifact. So you can see here that those papillary muscles are more present. We don't have any of that speckling that's present in this other image. That's going to come into play a little later when we talk about some of our advanced techniques. So if you're in cardiology, you've probably seen these images somewhere in the papers that you read. This is basic B mode or brightness mode imaging and M mode imaging. This is one-dimensional mode imaging to see how the heart is actually contracting over time. You go to your clinical cardiologist, these are most likely some of the images they're going to take. They're going to give you what's called ejection fractions, cardiac output, end-diastolic volumes, and systolic volumes. This is an indication of how well your heart is actually working over time. But what we know is that this type of imaging really is not as good as what it could potentially be. So if we think about the evolution of cardiovascular imaging, this M mode imaging is a one-dimensional image, right? You're taking a pinpoint of a very small portion of this heart to say, this is the overall function of my heart. Well, not exactly. So this kind of led to two-dimensional B mode imaging. So now I'm taking a bigger portion of the heart to try to see a contractile pattern, but it's still a one slice through the heart. 3D imaging, okay, so we can move now during the entire length of the heart, but are we in systole, full contraction? Are we in diastole, full relaxation? And what's happening everywhere in between? So these types of imaging make temporal and spatial assumptions. What we have on the F2 is something called 4D imaging. This is actually allowing you to add the three-dimensional acquisition with a time component. So you get the actual motion of each contraction throughout the entire heart. How does it do this? Well, it uses a portion of our software called EKV imaging, or ECG kilohertz visualization. This is the highest potential level of imaging that you can get for these structures. So if you think about a heart that's contracting at 400 beats per minute, that's pretty fast, right? If you don't have an ultrasound system that's functioning at a frequency that's similar to that, you're missing portions of that contraction because it's only going to be able to snap an image so quickly. So this allows us to get those finite images snapped. So again, you see the valve coming into play. You can see areas that might be stenotic, meaning that they're not really moving as well as they should. And this tells us everything we need to know about how the heart is really functioning. So that 4D acquisition allows us to get an image that looks like this. That looks like a cardiac MRI image, which is the gold standard of what you would do in the clinic. So speaking of gold standard, that's great that it looks that way, but we want to quantify our results, right? Because it's great that it looks that way, but we need the numbers. So we've had customers that have validated this 4D imaging technology against MRI. And what they found is that you get more accurate measurements with 4D ultrasound versus MRI than what you would get with just M mode measurement, which is what a lot of people still actually do. So this allows you to get these beautiful, clinically relevant images in a fraction of the time and a fraction of a cost if you were actually doing these through MRI. Now, one thing that I'll tell you that's great about the F2, and again, if you use one of our older systems, you're going to know this, the chip processing in the system allows this particular acquisition to go 3 times faster than our previous model. So an acquisition that used to take 8 minutes is 2 minutes. You can get an MRI-based image in 2 minutes. That's almost unheard of anywhere. Okay, so what else do we care about? Well, we care about right ventricle. All those imaging modalities you can do in the right ventricle as well. You can also do them in the atria. So looking at how atrial contraction takes place, looking at the true volumetrics of the atria changing over time. You want to go in and potentially inject something in the heart, you can do image-guided needle injection. You no longer have to do a very invasive procedure where you're surgically going into the animal and they need 3 days to recover and 3 days of pain meds before you can ever do anything to them again. This is just a needle being put into them, and it can be put in the same place over and over again very consistently. Okay, so this was all kind of the B mode and M mode based imaging that you can do. But we're interested in seeing things like blood flow as well. So this requires something called color Doppler imaging. Color Doppler imaging allows us to utilize the Doppler shift principle. Basically, blood that's flowing towards our transducer is red. Blood that's flowing away from our transducer is blue. It doesn't actually tell us which ones are arteries and veins. You kind of have to think about, is this vein coming towards my transducer or is it an artery? But these are great diagnostic tools because they can help us actually determine, oops, if they're, oh no, oh, don't crash on me now. Okay, if there is some turbulent flow that's happening. Well, in that particular TAC model, that's a transaortic constriction model, you can actually see where your band has been placed around the aorta just based on that flow pattern. Those are qualitative. How do we get quantitative? We add pulse wave Doppler imaging. This allows us to go in and get many, many measurements off these blood flow images to say, is this diastolic dysfunction? Is it systolic dysfunction? We can use things like tissue Doppler. Ugh. So sorry. Tissue Doppler. Tissue Doppler allows us to go in and look at valves that are moving over time. Are these valves getting stenotic in our animals? These are the same things that your clinical cardiologist is going to be doing. I want to kind of break away to this other add-on portion of the system called the Laser X. This is something that does photoacoustic-based imaging. Photoacoustic-based imaging uses near-infrared laser light that's basically put into the system. This gets absorbed by chromophores that are sitting in the system. Once it absorbs that laser light, those tissues expand, and those generate a sound image that gets kicked out back to you. This allows us to co-register ultrasound images with molecular imaging. So think about what you would do with an IVUS system. You'd image some molecular compound that you put in there, kind of shows you a general area in the animal that it went in. Now you're going to be able to see the organ and structure it actually went into. So this is great for doing things like tissue hypoxia work, tissue oxygenation. You can do contrast imaging with various molecular agents. You can also look at whole body distribution. I just gave a drug to my animal. Your reviewer says, well, where did that drug go? If you just injected it IV, how do you know it went to where you care that it went to, or that it's not sitting in another organ? This can tell you that. So I mentioned that there are these contrast reagents. You've got endogenous ones that sit in you already. Hemoglobin is a natural absorber of near-infrared light. So is melanin. You can also inject ones. There are near-infrared dyes. There are things like nanorods, nanoparticles that can be generated. So you have the potential to work with someone who knows their chemistry that can generate one of these to image almost anything you can think of. The individual molecular components are going to have very specific absorption frequencies. You learn what those are by imaging them on the system, and then you do what's called spectral unmixing. So here is a subcutaneous tumor. In red, this is highly oxygenated areas of the skin and of the tumor. The blue represents what we call deoxygenated hemoglobin. This yellow is actually a gold nanorod that we've injected into this particular tumor. So again, looking at distribution of things that you're injecting. Okay, So that's the science behind it, right? What can you do with this? Label stem cells and start injecting them into the heart. Follow those over time. See if they're regenerating. See if they're being taken up. Oh no. Oh no. All right, just a moment here. I apologize. Does anybody have any questions at the moment? Let's just boot this again here. There we go. Okay. Follow the heart actually contracting. Follow the oxygenation that's changing in the anterior wall. You're doing ischemia reperfusion. You're doing coronary ligations. You're giving these animals heart attacks. You need to see how the oxygen is changing in the heart. Okay, so vascular imaging, I'm going to blow through this pretty quickly. All the same modalities that you've been using or that I've previously shown you, you can do for vascular-based imaging. Use color Doppler to show where a plaque is sitting in your atherosclerotic models. Image that coronary artery and show potentially where your blockade is. So remember, your coronary artery is like a piece of dental floss. That's how small we're getting in these animals. So this, again, is the kind of resolution that you can get with our system that you would not be able to get anywhere else. That 4D imaging that I described before, it's not just for the heart. You can use it on contracting blood vessels as well. You're using an aortic aneurysm model and you want to see where that huge aneurysm is developing, you can do that with the 4D and you can actually size that aneurysm. Size your aortic arch. Determine where plaques are actually sitting in there and show people in publications using this wire mapping. Here's where we're actually getting disease forming over time. Okay, so I'm going to totally switch gears and go over to more developmental or embryology, because this is another natural thing that we think of when we think of ultrasound, right? Again, in the clinic, we think of people monitoring pregnancy. Monitor pregnancy. Confirm pregnancy in your animals. We talked about doing some 3D-based imaging. You can use that 3D imaging and see how many animals are actually sitting in the uterus of your pregnant mouse. So this is not something that you even have to anesthetize the animals for. You can literally just pick them up, scruff them, turn them over, and have the transducer run across them. This is a very quick process, just to say, nope, my animals need to grow for another 2 days before I start actually doing my intervention. So it's a really quick way to do this. Our high resolution allows us to see the smallest possible structures in these developing embryos. You can determine eyes. You can see abdominal aorta. You can see the ventricles of the heart being generated over time. Come on. Love this image. Unbelievable that we can actually see the aortic arch of a developing embryo and get true blood flow off of that. That's pretty unheard of. So if you want to see various cardiac abnormalities that are developing in utero, you can do that. You can do 3D imaging. You want to look at the umbilical artery, the umbilical vein. You can image those in 3D. Got something else here called power Doppler imaging. Power Doppler isn't really used in cardiac imaging. It's something that will be used more in tumor-based imaging or in developmental imaging. It's a more sensitive form of Doppler, but it gives you no information about directionality. So the red and blues are not there. So we can pick up tinier vessels, but we don't know where really they're going or what speed they're at. So you can take real measurements from the maternal source, the maternal uterine artery. You can look at placental vascularity. You can get measurements off the spiral arteries. Now, spiral arteries, these are relatively low velocity blood flow in comparison to everything else we're looking at. So you can imagine if we've got a transducer on the abdomen of the maternal source, every time she takes a breath, that's going to move these animals slightly out of position. What I'm showing you here, these yellow bars across the ECG and respiration signal, is that we can do what's called respiration gating. So we can actually say, just don't collect the image as the mother is taking a breath. And this will prevent us from getting huge smears of color coming through our images. So again, less artifact, more appropriate measurements that we can get. That image-guided needle injection, you can inject into the amniotic fluid. Again, this is non-invasive. You see all of this. We have our needle slightly off screen. We have a trajection path that we can actually map out of how our needle is going to move into the system. and we can do injections. What if you don't want to go into the amniotic fluid? What if you wanted to go into an actual structure in the animal? Well, this is slightly more invasive. You can do a midline laparotomy and actually expose the individual developing embryos. But you can do things like brain injections once you've done that. So think about injecting an siRNA midway through development and then seeing how it changes in the actual birthed animal. So all of this is possible. If you combine this with photoacoustics, now we can look at oxygenation levels that potentially change in the placenta over time. We know that this has a great effect on substantiating pregnancy. I don't know if anybody follows COVID research a lot in this particular field. Just new research came out about women who've contracted COVID, not even an active case of it. They are developing what's called placental stiffness. They believe that this is what is causing more women to have stillbirths later in pregnancy now, once they've had COVID infection. This can actually be used as a tool to help monitor some of that. Okay, so let's now shoot over to oncology. Let's just, again, we're using the same modes each time. We're just putting them in a different animal model. How do we start developing tumors in our animals? Well, we use image-guided needle injection to inject tumor cells into specific organs. So here we're looking at the bladder, and this triangular structure over here, right there, is the prostate. We can do image-guided needle injection into a variety of structures. I like showing this one of the bladder. I don't know if anyone's actually working in bladder cancer, but most of the time what you're trying to do is inject into the actual wall of the bladder. That's like a paper-thin structure. Older systems, that's almost impossible to see where that lateral wall is. You can easily tell the difference here and then target that with the image-guided needle injection. So you might be saying, well, you know, I can still inject cells by just quickly making an incision, like going into the animal. Like how is this really any different? I understand like there's a little bit of concern for the animal welfare, but this is the method I'm used to. Well, there have been publications that have come out that have said we've gone and analyzed image-guided needle injection versus the surgery model. We actually get more consistent tumor placement and development when we do image-guided needle injection versus our surgeon who's been doing this for 25 years, cutting the animal open. So you'll get more consistency in your animal models by using this technique. Okay, so we've injected our cells, now we need to watch them grow, right? Most of the time we don't know a tumor's there until we can feel it. And then that tumor's massive. How clinically relevant is that? I don't know. So we need to be able to look at these tumors when they're very, very small. Because we have those high frequencies, we can see these tumors when they're only 30 microns in size. That's incredibly small for a tumor. So you can start to look at these small tumors develop and again decide, am I ready to start working on this animal? Am I ready to give it my drug? Not yet, let it grow for 2 more days, scan it again. Again, you don't need to anesthetize them for this. This can be very, very quick. Once you actually get your tumors to grow to the size that you want them to be, you don't need to use a caliper. Again, hopefully they're small enough you can't even really feel them with your hands. You're just visualizing them through ultrasound. You can do volumetric work with the 3D motor. These tumors have been published over and over again. 3D acquisition and tumor volumetrics is the same as what you can get in histology. So this is great, right? You're reducing the number of animals that you need to use. You're reducing the amount of money that you're spending because you don't have to purchase as many animals. You don't have to house them as long. And you can 3D the size of organs too. It doesn't necessarily just have to be the tumor. So you've got an ovarian tumor developing over time. It's kind of hard sometimes to distinguish that ovarian tumor from the actual ovary. You can just look at the overall size. Air is kind of one of these interesting enemies of ultrasound. We need something for our sound wave to bounce off of. Colon would maybe potentially not be an intuitive application. You can actually fill the colon with ultrasound gel and look at beautiful colon tumors that are developing over time through this 3D acquisition. And I'll tell you that these particular colon tumors we're going to revisit in just a minute. But now that you've gotten the size of your tumors, let's talk about blood flow to tumors. What is the vascularity? You're killing me, computer. Any questions at this point? I apologize. So basically what I'm going to show you is we're going to be running through the color Doppler imaging again, showing you the vascularity that's developing in the tumor over time, showing you the various pulse wave sequences that you can detect as you're going through the tumor. I was joking with Adrian earlier that these videos are massive. Usually they don't cause my computer to crash. But naturally, it only happens when you're in front of people. Okay, so let's do this one more time. Okay, so looking at our pulse wave sequences that can be generated. Oh no. Is your IT person still available? Hmm?
Do we have to have someone in here?
I don't think so. I apologize. Oh, here we go. Beautiful.
Okay.
Okay. Nothing else is going to go wrong, I promise. Okay, so beautiful pulse sequences generated. I spoke a little bit before about that power Doppler-based imaging. This is beautiful for tumor work. Look at angiogenesis that's developing over time. Now, I told you before that Doppler-based imaging is really more of a qualitative thing, and when we use pulse wave imaging, it becomes quantitative. If you do a 3D acquisition of this, it actually can become quantitative. We can look at overall percentages of vascularity that are developing in tumors over time. Beautiful thing about the F2, this Doppler-based imaging is faster than it's ever been. Again, because of these system components that are built in to the F2-based system. So looking at hemodynamics, we may also care about perfusion kinetics. Has anybody ever heard of microbubble imaging with contrast reagents? This is definitely something you can do with the system. We have microbubbles that have been generated by Bracco, one of the clinical manufacturers of microbubbles. These are roughly 2 to 3 microns in size, so you can get infiltration all the way down to the level of the capillary. Now, these exist in a native state that will just go through and show you basic perfusion kinetics, but you can also tag them. So basically, anything that can form a biotin-streptavidin conjugation can be targeted with these microbubbles. So again, just in their native state, we can actually use this as a diagnostic tool, even if you don't want to do any type of quantitative things with them. In a normal liver, we see beautiful perfusion kind of coming through that liver, right? You can see all the branching of the vessels that come through. I'm going to show you this bottom image, which is actually a liver that's riddled with tumors. I'm looking specifically at this area right here. Now, tumors can show up as either these hypoechoic, black circles essentially, or very bright white, hyperechoic areas. So these tumors, I don't know if you can see that this is a little bright in here maybe, this is actually showing me tumors that are there that I can't see with my naked eye just in this image. So again, this is a great diagnostic tool to help us see where tumors might exist. Also great for cardiac imaging. Once we go in and perform a coronary ligation, we can get scar tissue that develops. Hard to image around that scar tissue. It can make large black shadows. This microbubble contrast reagent can actually help us see where the walls of the chamber of the heart are existing. So I told you we'd kind of jump back to this colorectal cancer model. This is another one where they've actually generated those targeted microbubbles to look at very specific micromarker expression in these tumors over time. So you can see that they are identifying a tumor for us. And by using some of our very specific software that I'll talk about in just a few moments, we can get beautiful parametric mapping kind of showing the development of these tumors over time. Really fascinating work that's being done at Stanford working on B7H3. This is a ductal carcinoma cell model of breast cancer. This is one of the hardest to detect. Once you have it, it's difficult to treat. Prognosis can be not great for these patients. They've actually used these microbubbles to say, this is a human B7H3 cell line. We've generated our microbubbles to detect that, and we can accurately detect where those tumors are versus tumors that don't have B7H3 in them. We're going to come back to this in just a minute because this is really, really fascinating work when we think about where this goes clinically. So just looking at perfusion, we also want to then use that laser system, that photoacoustics, to look at oxygenation in tumors, right? We hope that they're regressing over time. Those tumors are dying. So you can use photoacoustics to look at how oxygenation changes, and not only oxygenation, but also the recruitment of hemoglobin to tumors over time. You can subject them to various challenges and get live imaging of changes that occur in the tumor. So this is just one example where we've subjected our tumor to various concentrations of oxygen, and we see how it responds versus surrounding tissue. If you wanted to get more sophisticated than just looking at oxygenation in the tumor, you actually want to look at a drug you've injected, you can do that live. Now, this is really unique to Visual Sonics. There are other photoacoustic manufacturers or companies that sell photoacoustic-based systems. None of them can do a live injection imaging. So what we're actually seeing here, this is just methylene blue. Methylene blue is a natural absorber of photoacoustic light. It's injected into the hind paw and transmitted up to the popliteal lymph node. Once you watch that live injection of where your specific reagent likes to go, you can do the 3D imaging and again see the concentration of your specific reagent. So again, if you looked at this in IBIS, this would be just a huge smatter, and you'd say, okay, well, I mean, I think it's in the hind limb, but where is it in the hind limb? You're actually seeing the structure it went into. So that B7H3 ductal carcinoma model I just told you about, they then use their antibody to tag ICG to the B7H3. Why is this important? Microbubbles only stay in circulation for like 20 minutes. If I wanted to go in and remove a B7H3 tumor from a patient, I've got 20 minutes before I have to then inject them again with this contrast reagent. ICG will stay in the body for 96 hours. I can do live imaging during surgery to remove cancerous tissue and make sure that I've gotten it all out. So you can think about those clinical implications of what photoacoustics potentially has. Imaging in the brain definitely can be done with ultrasound. You can do it with the skull intact. This is one example of melanoma that's metastasized to the brain. So again, this is melanin's a natural absorber of the photoacoustic light. You're not just using one technique, you're using multiple techniques, right? So you're seeing how blood flow changes with the tumor. You're seeing where the tumor actually lies. This gives accurate size of the tumor that was detected with photoacoustics as histology did. So again, you don't have to sacrifice your animals to get this kind of information. I mentioned you can look at biodistribution. This actually requires one of our new features called the whole body setup. This allows you to change the direction of how you're putting in this near-infrared light into the animal. This particular image is just accomplished by using something called angiostamp. It's a very specific near-infrared molecular agent that targets very specific types of tumors, pancreatic tumors and things. This is just simply showing you a 3D generation of where all of that angiostamp is sitting in the body, and we see the majority of it is sitting in the kidneys. Now that you've identified where your drug of interest has gone, now the process starts all over. What's the function of that organ that that particular reagent went into? Because that's what your reviewer asked you for, right? So all of this can be accomplished with this one system. And I've only shown you like a small subset of the types of tumors that people are working on, many, many different animal models. I promise you I'm coming to the end here. Okay, so since I spoke a little bit about brain, I'm gonna quickly bang through what we have for brain. There's a neuroatlas to help you start to identify various structures. We have stereotaxic ear bars that help you get consistent positioning of the animal over time. You wanna look at blood flow in the brain? Do it using color Doppler, using the power Doppler-based imaging. you can also look at tiny blood flow of individual micromarkers going through the brain over time. This is accomplished, again, through our contrast-based imaging. Contrast-based imaging crosses the blood-brain barrier. So all you need to do is a tail vein injection. It's going to go right into the brain, and it's going to go through those major blood vessels that are there, again, all the way down to the levels of the capillary. Why would this be important? Well, any stroke-based ischemia model that you might want to be looking at in the brain, beautifully visualized this way. By selecting your regions of interest and using our parametric mapping, you can easily identify areas that are hypoperfused. If you don't just care about blood flow going there, again, you want to look at oxygenation of this area. Let's say you're doing an ischemia reperfusion model. Photoacoustics comes in, again, to give us this beautiful imaging. And one thing that I'll say about F2, again, because we have these lower frequency transducers now, we could never do this in rat before. This is really reserved to just mice. We now can do this in rat. We can get deeper penetration, more photoacoustic energy targeting to those areas. So you can see before kind of what we had in terms of depth of penetration, not great. We have it all the way through the brain in the rat now. Okay, so I want to quickly just talk you through a couple pieces of software that we have. The system comes with something called Vevo Lab. That's your basic analysis suite. In that suite, we give off free features and upgrades all the time. And again, right now, we give them away for free, and we've done that for the past 20 years. So every time we release a new software update, you get that automatically. New feature that we just released is a pulse propagation velocity tool. This is an automatic detection of the velocities at two ends of the vessel, looking at blood flow. So it's a time-distant velocity component. You also can do infarct sizing. New publication that just came out with our 4D imaging. This is really revolutionary because you've never been able to actually estimate the size of an infarct without actually killing the animal and taking it out and doing histology for it. So that's now been validated with 4D imaging. Don't like to spend a lot of time doing analysis? Who does, right? Like that's the crux of every experiment that we do. We have AI analysis tools for some of our cardiovascular measurements where you before had to go in and say, all right, this is in systole, I'm placing this point, this point, this point, this point, now go all the way to diastole, place these points again, now process the image. Same thing for this. Point, 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 like so on and so forth. Now all you need to do is highlight this area. 7 seconds to analyze this image. And we've had a really nice publication that came out of one of our European groups that said, you know what, we did this in mice, we did it in type 1, type 2 diabetes, fibrotic models, TAC models. We did it in rats in all these models. And what we found is that whether we manually go in and do this or whether the software does it for us, we get the same measurement. And we can do that up to 46 times faster. So those of you that don't have any idea how to use the software, you've never looked at this image before, you don't have to. This is going to do it all for you. One really sophisticated piece of software is called Vevo Strain. Cardiac strain is a measurement of deformation of the normal contraction pattern. Strain is an incredibly useful tool in the clinic. They use this all the time to look at early dysfunction. So if you get to the point where your ejection fraction has fallen, you're already in trouble, right? If you look at the New York College of Cardiology, you're already considered in various stages of heart failure. So by identifying early dysfunction that happens, you've got better intervention that can take place. That's also the case when we think of chemotherapy. One of the biggest things, if you're on chemo, your oncologist should do is put you in contact with a cardiologist. You need to be monitored simultaneously. If the ejection fraction of your heart has changed because the chemo drugs are so toxic, you've already done enough damage with chemo and they need to change your course of treatment. So by using cardiac strain, we can monitor your heart before you've damaged it, before there's no recovery. Because if you remember, cardiac tissue really doesn't regenerate itself. It's not like other muscle tissue in the body. So how does strain work? This is not just looking at the basic contraction of the heart. The heart contracts in 3 different ways. It has your radial squeezing, it has your longitudinal compression, and it also has circumferential twisting. So all the time your heart's going like this. If you're just looking at your one M mode image, again, you're getting a single snapshot of what potentially is happening. So strain allows us to look at not only strain, that conformational change that's happening, but velocity changes, displacement changes that happen over time. So I'll walk you through each of kind of these 4 panels. The first one is basically just the trajection path of how you're watching the heart contract. And I'll say that this does this through speckle tracking. So once you kind of trace the outline of the heart, it's following pixelated differences. This is where that spatial compounding and that HD processing is so important. If we've got a bunch of pixels sitting in the cardiac tissue, it's going to follow the wrong one. And your heart contraction pattern is going to look like it's all over the place. So the newer systems allow this software to be more accurate because it's not accidentally following the wrong pixel when it contracts. So you're going to get functional parameters off of this. You get things like ejection fraction and cardiac output, but the thing you really care about is this GLS, this global longitudinal strain rate. That's the number that the clinical cardiologist cares about. And again, it's generated from looking at contraction patterns of various areas of the heart. So here we're just kind of looking at the anterior wall, that septal wall, and all the way down to the posterior wall. And depending upon how that contracts, it's going to generate these nice parametric maps that say, okay, systole is perfect and diastole is perfect and your heart's functioning normally. But when things start to go awry, it generates patterns that look something like this, that say your heart is actually contracting in a very different pattern of what it should be, and it might not have changed ejection fraction yet, but that is potentially coming. Or, as anyone that works in cardiology knows, these HFpEF models, heart failure with preserved ejection fraction, this is the tool that you need to use to look at these particular hearts. Now, we can also look at things like quantitative segmental synchronicity. And again, this is all information about how your heart is contracting over time. The vascular imaging people in the audience, there's a special software just for you. This is called Vevo Vasc. It does essentially the same thing that the strain software does for the heart, just for the vasculature. You're looking at displacement and contractile patterns that happen in your larger vessels. Anybody using contrast-based imaging, you can do a little bit of analysis in Vevo Lab. It's very limited. You can look at time to peak values and peak contrast amounts. That's it. This is the only thing you're going to be able to generate in terms of the data you're collecting. If you opt to have something called Vevo CQ, this is the thing that's going to generate the beautiful parametric maps. That's going to give you more information than just peak enhancements and time to peak. It's giving you area under the curve, rise times, washing times, perfusion indices. This is really the software that you want to use. I'd like to just end the talk by saying, you know, Visual Sonics, we're always striving to create more tools that help our research. And I'll tell you that everyone that is on our developmental side, that's on our application side, we're all PhD people. We've all used the system before for lots of different things. We're the ones testing and working with our customers to try to develop these new interesting things. This is actually an interesting piece of software called MULM. This is a motion-based ultrasound software. This is for looking at that super resolution thing that I talked about before. So nonlinear contrast, it's a good tool. It does have some limitations. It's got good sensitivity for detecting vessels. There's decent background suppression, and you can get some perfusion kinetics. What we can't do is follow individual bubbles. This is following many, many bubbles over time. So what MULM software allows us to do is to track individual bubbles as they're going through the brain or through tumors. This is really, really crucial to Dr. Song's work. This is the thing that he's actually working in. So MULM is a motion model ultrasound localization microscopy, essentially. It allows you to kind of get down to that level where you can look at those individual bubbles. And again, this is going to allow us to look at things like vessel density, the tortuosity of those vessels, the velocities and directions that they go in. So if we think about what we can do with this particular piece of software, we can look at vasculomics, we can look at various neuro applications, various tumor applications, and to generate an image that looks like this, essentially, without having to do all that bioengineering on the front end. So even with my system crashing, we still made it in time. So I'll take any questions that anybody has. Yes.
I work on atherosclerosis in mice, and I saw some of your images and you suggested that it can be quantified. Yeah, I would like to, if you have knowledge of any publication that has used your system, because I would definitely be interested in seeing how comparable it is to the histological quantifications.
Yeah, absolutely. So if you can stay around a few minutes afterwards, I'm happy to give you my card and we can exchange information and I can send some publications over to you.
Thank you.
Of course.
Also, second question.
Mm-hmm.
So, well, you said a lot about labeling, like I guess with fluorescents or specific dyes or agents. What is the resolution of that? Basically, can you go to cellular level if it's like some type of solid structure, like a bead?
Yeah, so I'll say we cannot go down to the cellular level. And when I talk about IVUS, I just want to be clear, we're not looking at fluorescence-based imaging. We're in the 680 to 970 range, or 1200 to 2000 nanometers. Most of your fluorescence is lower than that. That's like 640, 600, 580, something around those ranges. So you're not going to be able to put GFP into the system and see it. We cannot get down to the cellular level.
Well, I mean, they sell these beads, dyna beads that are fluorescent, but they are like solid particles, and then you can inject it and cells take it up. They are very like sturdy, I guess. I don't know. I'm wondering how it looks if you can see that.
So,
Size, right?
so whatever reagent would be inside of that bubble would have to be something that's an absorber of photoacoustic laser light. So again, within that wavelength range. There also needs to be a certain concentration that's present. That's different for every single reagent. So we would need to just determine what that is in-house with some pilot experiments.
Okay. Thank you.
Uh-huh. Yes.
I have a question. I study intestine, so I'd be super interested on the guided injections.
Mm-hmm.
But the intestine of every animal sits differently.
And it also moves.
Yeah, exactly. And so I'm kind of wondering how, we have landmarks if we're going to open up the animal and look for it. And I know you were talking about depth as like a certain marker that the machine can memorize. How easy is it to have a ballpark and then guide that injection?
Ballpark is easier, so we'll use a loose definition of ballpark here. So in terms of specific areas of the small intestine or of the colon, we can hit transverse colon for sure, those types of things. Can I get down to the same millimeter we're never going to be able to get to that level again because it just moves, it contracts. Even when we're sitting there imaging it in the same plane, it will move while we're doing that. It's also a structure that's full of air, so there is nothing for it to bounce off of. So we recommend that if you want to do stomach-based imaging, intestine, stomach in particular, that you don't feed the animals overnight, and that will reduce some of the artifactant things that are there.
Okay, great.
So we can have one of our application specialists, work with you on your particular model to try to give you some tips and tricks that they've learned from various sites that they've visited over the years. And of course, we're happy to put you in contact with any other scientists at another institution that we know.
Great. Thank you very much. Good
Yeah.
to know that sort of service is available.
Yeah. We do everything we can to potentially help our customers succeed. So,
Well, I have another question.
yeah, please.
How much is the machine?
Oh, I'll defer to my colleague.
There's a lot of different options that Sarah covered. So ballpark, the Carver grant that's been submitted for the basic ultrasound system with all the software is about $500,000. To go to photoacoustic jumps up to about $900,000.
But these are like fully loaded, right? So each mode that you put on the system, each transducer that you purchase, those are all additional add-ons.
Like that you basically mentioned, like this kind of addition. Okay.
Yeah. So let's say if you did not need power Doppler imaging for any of your studies, then we just wouldn't put that on your system, and that's, you know, you don't add in that particular cost. Same thing with your transducers. We'd say, well, you only have money for 2 transducers. These are the majority of the animals that you're using. You can get away with these 2 instead of needing 3 or 4.
Okay, so this is obviously an instrument that we're looking at purchasing. You should talk to Adrian about that if they're at all interested or know someone who might be interested. And let's thank Sarah again.
Yeah, thank you.
And there's a little bit of pizza left. You guys should grab some pizza right off.
We'll leave it for the
Save it
students.
for the students.
Yeah, the students. The students get it.
Okay, well, thank you.
Thanks, everyone.
That
Thanks.
was-
And I think there's a few things on this front table.
There's a couple brochures,
Oh, pens.
pens.
That is really good. I really like it.
Yeah,
These
yeah.
ideas, I really like your presentation.
Oh, thank you.
Very nice.
Thank you.
Yeah. So yeah, I mean, I work on Athero, so we do endpoint analysis, right?
Mhm.
And that's one of the issues that we have because and now there's more people that they have new models of atherosclerosis, like injections that develop atherosclerosis over time, and you never really know
Yeah.
when you're supposed to kill the mouse. So that type of machine will be very useful because we also study the regression of the disease, so we